I'm turning it over to Dr. Bruce Wang. We're very fortunate to have him be not just an expert in porphyria, but also a very much loved Porphyria Scientific Advisory Board member. It is always a pleasure for him to come in and give us some of his knowledge. So today, Dr. Bruce Wang, I know that you're visiting us from the University of California in San Francisco. You run the Porphyria Center, and you're the principal investigator of the U.S. Porphyrias Consortium as well. So very excited to have you here. Thank you for your time and your energy given to the UPA this morning. So with that, I am going to kick the time over to you, impart your knowledge to us because we are here to learn from you. Take it away.
Thank you, Myra. Good morning and good afternoon to some of you. I'm currently in San Francisco. I'm a hepatologist. I also run the Porphyria Clinic here at UCSF, as Myra said. So today we're going to talk a little bit about one of the potential complications, especially for patients with acute porphyria, and that is liver cancer. What I thought I would do is I'm going to go through a few slides here and talk a little bit in general about what we know of liver cancer and the acute hepatic porphyrias, and also a little bit of what we don't know and what our current recommendations are for monitoring for liver cancer in patients who have AHP. And then I want to leave most of our time together for questions. All right. Okay. So we're talking about liver cancer and the acute porphyrias. Why are we talking about that? Well, that's because we've known actually for many years, this is across from data from actually throughout the world, that patients with acute porphyria, and this is true especially for patients with acute intermittent porphyria because we have the most data for those patients, but we think patients with variegate porphyria and hereditary coproporphyria also have increased risk. What I'm showing you here on this slide is one of the more recent studies. This is coming from Sweden. Really, this graph, the only main thing I want you to focus on is on the y-axis here. This is the relative risk of developing liver cancer. On here is over years, and this is a little over 1,200 patients with acute porphyria that have been followed for, on average, over 20 years. And they also took some the general population in Sweden. And you can see here in these two graphs here, this one in blue in women with acute hepatic porphyrias, and in red in men with acute hepatic porphyrias. Both of those populations have a higher risk of developing liver cancer compared to the general population. All right. So this is why we've been concerned about the risk of liver cancers, because the observation is that acute porphyria patients have a higher risk compared to the general population. Well, how high really is that risk? Well, when we talk about in the liver field, when we talk about risk of cancer, we tend to express it in terms of what is a person's risk of developing cancer on a year annual basis. Right? That's just kind of how as a field, we've been looking at expressing this risk. And so if you start here in the general population, all right, and now this is mostly based on data US and Western Europe, the risk of developing liver cancer is really low for any general person in the population. It's less than 0.01% per year, okay? The data that I just showed you, plus others, when you pull it together, tells us that patients with acute porphyria, and this is specifically based on patients with acute intermittent porphyria, who are over the age of 55. Okay, so if you're in that population, your risk is quite a bit higher than the general population, right? Almost 80 times higher. Okay, I'm listing you down here two other types of liver disease patient populations who I see regularly as a liver doctor, who we think about the risk of liver cancer quite a lot. And these are the two patient populations that I use as a reference here because their risks are high enough that we think we need to monitor for liver cancer on a regular basis. So the first population are those patients who have chronic hepatitis B. So this is a virus that infects the liver and increases the risk of liver cancer. And patients with chronic hepatitis B who don't have much underlying liver injury, we'll get back to that in a second, they have a risk about 1.5% per year. And then we have the patients who have had liver injury from whatever cause, fatty liver disease, alcoholic liver disease, or a viral infection of the liver that has led to an inflammation and scarring over many years to the point where they have a condition called cirrhosis. So this is where you have a lot of scarring in the liver to the point where the liver doesn't work normally anymore. In that population, their risk of developing liver cancer is 2 to 3% per year. Okay, I'm highlighting these two because this is about the time where the risk is high enough where we want patients to start doing more screening for cancer. Right, so this would be similar to, for example, why we would do colon cancer screening in adults over the age of 50 is because that's when the risk of developing colorectal cancer is high enough. Or in women, the screening guidelines for doing breast cancer. So that's based on the population risks. And so for liver cancer, generally, when your risk is around 1.5 or so or higher, that's when we start wanting to screen for liver cancer. Okay, all right. So if you have the general population of patients with acute intermittent porphyria over the age of 55, you've got some risk, okay? But we also know that patients with acute porphyria, acute intermittent porphyria, some are symptomatic, some are not. Some have frequent recurrent attacks, some have sporadic attacks. Do all patients have similar risk, right? And so again, I'm showing you some data from Sweden here, published from Matthias Lissing's group a few years ago. It turns out that if you look at all of the Swedish porphyria patients and you separate them based on disease severity, in this particular case, we're only separating patients based on whether or not they have ever had urine porphobilinogens that were abnormal. Okay, and what you can see here, what I want to focus on here is the red line here. Those patients who've never had an elevated urine porphobilinogen, even if they have the underlying genetic defect that causes AIP, those patients have the same risk as the general population. It's really low. And it's really those patients who have had, really symptomatic acute porphyria that have the higher risk, okay? And so if I modify that previous graph a little bit and we add this other second group over here, that those patients over the age of 55 with acute intermittent porphyria who have had symptomatic disease. And in this case, I'm grouping together everybody who's had elevated urine porphobilinogens ever in their lifetime, ever been hospitalized for an acute attack, ever been treated for an acute attack. And if we look at those patients, their risk is around 1.8% per year. Okay. And in fact, actually, if you separate this group out and look at only those patients who've never had symptomatic disease, that risk is probably quite a bit lower than the 0.8% per year. Okay. All right. So how do I put that together? What's my recommendation to my patients with acute hepatic porphyrias? So the general guideline in the liver field for when we start recommending regular surveillance for liver cancer is if somebody's annual cancer risk is greater than 1.5%. Okay. And so that applies to those patients with chronic hepatitis B, certainly applies to patients with cirrhosis. But we now also applies to patients with acute intermittent porphyria. This was an expert guideline that I helped co-write a few years ago, and where we recommended to the gastroenterology community that in terms of best practice, that for all patients with AHP, regardless of the severity of the symptoms, they should start undergoing surveillance for liver cancer starting at the age of 50 with an ultrasound every 6 months. Okay. So, and this is by and large how the porphyria clinical community recommends the practice is that if you carry the genetic mutation for one of the AHPs, whether it's AIP, variegate porphyria, or hereditary coproporphyria, once you reach the age of 50, your risk of liver cancer is increased and you should undergo liver cancer surveillance with an abdominal ultrasound once every 6 months. All right. So this is how we are currently practicing. There is within the porphyria clinical providers within our community, there is discussion about an alternative liver screening strategy that is a little bit more based on the actual risk of specific populations of patients with AHP. And so in here, where this would be a proposal to do a more of a risk-based, meaning if you're the data shows that if you're under the age of 50, your risk is very low. And the reason is because of all of the patients that have been observed, reported to have liver cancer and who have AHP, they're all actually 60 years of age or older at the time of diagnosis. So we really think that the risk of developing liver cancer in AHP patients below the age of 50 is really very low. And we would not recommend screening for those patients. Certainly, if you have AHP, in this case, I'm saying AIP because we have the most data, you're over the age of 50, and you've been clinically active with high levels of urine PBGs in the past, acute attacks, hospitalized before for acute attacks, you're at high risk and you should definitely undergo screening. And then there's this middle group that has kind of intermediate and unclear risk. If you have AIP, but you've always been symptomatic and your urine PBG has always been normal, I will add to this group the variegate porphyria and hereditary coproporphyria group because that group of patients we have far less data on. And right now, they're in some places. Some people are starting to do liver cancer screening recommendations based on this kind of risk. And if you're in this intermediate group, some people are recommending, some of the providers are recommending to not do screening. But overall, we need more data to show whether this strategy is safe. So the general practice and my own practice still is that if you're over the age of 50 and have AHP, you should be screened. Okay, but this is to say that more data is needed because I actually really am not certain if all acute hepatic porphyria patients over the age of 50 need to undergo surveillance for liver cancer every 6 months. Okay, because some people's risk may be actually much lower. So that takes me to my last slide, and this is a little bit of what we don't know about liver cancer and AIP and AHP. And there's a lot that we don't know. Starting with, does everybody need screening after age 50? That's what we just talked about. And also, is the risk of developing liver cancer and variegate porphyria and hereditary coproporphyrias as high as those patients with AIP? We don't have enough data on those patients. We really don't know how HCC develops, and HCC in this case is liver cancer, hepatocellular carcinoma. How does it develop in AHP? Does it go through the typical path of liver injury, scarring, fibrosis in the liver cancer, or is the underlying genetic mutation itself a risk factor for developing liver cancer? We don't know the answer to that question. More importantly, we don't know how much having high levels of ALA and PBG in the liver, those two chemicals themselves, may drive liver cancer risk. That question is important because it leads to the last unknown, which is, can we modify the risk of liver cancer in patients with AHP? Right. And this is where that earlier question that I posed of how much does having high levels of PBG and ALA matter and drive risk of liver cancer, because there are now ways for us to try to lower and suppress elevated levels of ALA and PBG more chronically. And the question is, will that have any impact on liver cancer risk? It's too early for us to say right now, but I think that will be an important question for us to answer as porphyria researchers in the coming years. All right. So, with that, I'm gonna stop, and I'm gonna open it up to questions. I think we've already had some questions that have come in. Myra, I'm going to ask your help in
Yes.
sending me the questions, and then obviously, if there are additional new questions, please feel free to send those to us. I'll try to get through as many questions as I can in the next 40 minutes or so.
Perfect. Thank you so much for that thorough explanation, Dr. Wang. I'm always blown away by your knowledge. We always walk away with so much more information every opportunity that we get to spend time with you. So we do have quite a number of questions. So I'm going to be asking the questions that we already have, but please use the chat, add any questions that you thought of while the presentation, and we'll get to those questions as well. Here goes the first one. Could a liver transplant really cure porphyria? And if so, when do you know that you're a candidate for it?
Yeah, yeah. Good question is relevant to our discussion about liver cancer and liver cancer risk. So, in all of the acute hepatic porphyrias, and I make a point of grouping AIP, variegate porphyria, and hereditary coproporphyria as acute hepatic porphyrias, because even though these are genetic conditions where every single cell in the body carries that mutation, it really is a disease that only manifests in the liver. And it's the liver that is the source of the abnormally elevated ALA and PDG that causes the symptoms of all of these acute hepatic porphyrias. And because of that, a liver transplantation is curative for for all of the AHPs. Even though this is a genetic disease, you haven't corrected the genetic mutation in all other parts of the body. Just replacing the liver with a liver that doesn't carry the same mutation will stop acute attacks from happening, will stop abnormal accumulation of ALA and PBG. Okay. Now, we've had patients with now who've been transplanted for at least 15 years now. I think we're the first patient that was transplanted maybe coming up closer to 20 years. This was in the UK. I am not aware of any cases of liver cancer developing in the transplanted liver. All of us in the liver research field also all believe that with a liver transplant, there also should be no further risk of developing liver cancer in the transplanted liver. So the answer to the question, yes, a liver transplant does cure you of your AHP. And that is because it's the liver's abnormal production of ALA and PBG that causes all of the symptoms and subsequent manifestations of the acute hepatic porphyrias.
I want to interject there for a quick second because I know of so many patients that we get to a point of desperation where we are
Yeah,
just super exhausted from breakthrough flares, those gnarly pains that come regardless of what we do, especially in women, where our hormones drive our flares. And not that long ago, I was on that boat. I had
yeah,
reached my level of desperation. And as many of you guys know, because I see so many familiar faces here, I reached the point of desperation and I didn't have any liver specific issues like cirrhosis or anything of that
mm,
nature. And I was about to submit myself to a liver transplantation, but I was able to see Dr. Bruce Wang and he looked at my chart, he saw everything and he goes, I think we're not done exploring all the options for you before submitting yourself to a liver transplantation. So coming from that point of desperation where I thought that that was my ultimate and only solution, I just want to give you a forewarning that if you ever reach that point, talk to an expert, talk to someone like Dr. Bruce Wang, who is an expert in liver, but also an expert in porphyria, because that conversation changed the course of my life completely. I'm no longer on the liver transplant list. We have a safe program that we're still going through. There's some ebb and flows, but I feel better than I did. And I think just the simple fact of like taking that big weight off my shoulders has brought me so much relief that the stress is no longer consistently consuming me. So, for anyone that's listening that is feeling like they're reaching that level of desperation, I highly urge you see an expert that really knows about porphyria, that really knows about liver before you make that final determination because a liver doctor who is a surgeon who's ready to perform a surgery might not necessarily have explored all the other options with you. They're there to cut. So make sure that you have an expert that has reviewed your case and has given you the green light to say, you have exhausted all options. This is our best course of direction. Because Dr. Wang, you really changed my life, and I just can't thank you enough for that.
So Mara, thank you for sharing that. That also actually reminds me, I didn't answer the second part of the question is when do we consider liver transplantation as
Mhm.
treatment for AHP patients? And so the follow-up on what I mentioned earlier, the liver is the source of the abnormal ALA and PBG. So um, I would consider doing a liver transplantation on a patient if, with current medication therapies and things, we cannot control the patient's liver from abnormally accumulating high levels of ALA and PBG, and those high levels of ALA and PBG are continuing to cause severe symptoms that lead the patient to, have recurrent attacks and need to be in the hospital all the time. Okay, I will say that since gavosaran has been approved and available for patients, that situation has dramatically dropped over the last 5 to 6 years relative to before. Okay, and so here's where I will also, echo what Myra just mentioned. What liver transplantation will not, where I would not recommend doing a liver transplantation is a liver transplant doesn't necessarily help you resolve nerve damage symptoms, neuropathy symptoms that may feel very much like acute attacks if those symptoms are no longer associated with high levels of ALA and PBG. Okay, that's actually been shown in the literature in patients who've undergone liver transplant with AHP, that the transplant itself doesn't necessarily get rid of the neurological symptoms. What it does do is it gets rid of the abnormally accumulating ALA and PBG. Okay, and so I think that's where um, uh, uh, we need to, if you're considering doing a liver transplant, the first question is, am I still accumulating abnormally high levels of ALA and PBG? Are those levels correlating with my symptoms? Is there anything other than liver transplant right now that can control that? Yeah.
Absolutely. Perfect. Thank you. And our fearless leader, Kristen, just mentioned in the chat that it's always a great opportunity for us to participate in research because this is how we learn. This is how we get to know more about this disease. So definitely let's make it a point to participate for sure. All right, moving on to the next question. If a CT scan is recommended annually, is it on top of every 6 month ultrasound or instead of the ultrasound?
Right. So the general recommendation for liver cancer surveillance purposes is ultrasound every 6 months. The reason is because with liver cancer, when it develops, it can progress pretty fast, and so we want to be looking on a regular basis, right? Because again, we're not sure if we can prevent and lower that risk, and so the purpose of the surveillance is that if you're to develop liver cancer, we can pick it up as early as possible because treatment for liver cancer, treatment success is way higher if you can identify it at an early stage. So that's why we're doing every 6 months imaging. Now, if you're doing imaging tests every 6 months, a CT scan every 6 months, starting at the age of 50, ends up giving people a lot of radiation exposure. Okay, so a CT scan is better at an ultrasound at picking up very small tumors. But the downside is that every CT scan gives you some radiation. Okay. And so that's why we recommend doing an ultrasound over a CT scan. Now, the CT scan is the next step. If something suspicious is found on the ultrasound, then we proceed to a CT scan. Okay. Now, you may ask also about an MRI. The MRI doesn't have radiation exposure, unlike a CT scan. There's two issues why we don't recommend doing MRIs every 6 months. Number one, there is some contrast, intravenous contrast that needs to be given, and there's a very small risk of it's a very tiny risk, but it's there of some kidney damage with MRI contrast. And then the second thing is that MRIs are expensive. Much more so than an ultrasound, and your insurance companies won't cover MRIs every 6 months for cancer surveillance purposes in general, unless there was a specific reason for it. And then the third thing is that, sitting in an MRI tube for, an hour, 2 hours every 6 months is a lot less pleasant than having an ultrasound where, you're just sitting in an open room for 10, 15 minutes every 6 months. So that's why the recommendation is to do ultrasound every 6 months. It's sensitive enough to pick up any tumors that are a centimeter or larger. And then if anything looks abnormal, the follow-up step, the next step is to do a CT scan or an MRI. Okay. Now, if for other reasons you've got another health condition that requires you to get a CT scan, or an MRI of the abdomen, that can definitely take the place of the ultrasound for that 6 month period. Okay. So if you had a CT scan to, look at your kidneys, for example, then you don't need to do an ultrasound for that 6 months period, because the CT scan will have given us just as good of a look, probably a slightly better look at the liver. If the CT scan is with contrast, okay, non-contrast CT scans, maybe not even quite as good as an ultrasound at picking up small tumors.
Perfect. Got it. Thank you very much for that. Speaking of tumors, this is a patient that was diagnosed 3 years ago with HCP, has never needed treatment. However, was told that they have a benign tumor in the liver, and sometimes there's throbbing in that area. Should she or he, should they ask for further testing? What's your recommendation?
Yeah. So there are a number of benign growths in the liver. They vary in risk of eventually developing into a cancer. And so, based on the relative risk, some require no follow-up, but others require regular follow-up. So part of the answer to this question is depends on what kind of benign growth, benign tumor was identified in the liver. So, for example, on the very safe end, we can pick up things on our surveillance ultrasounds, like a hemangioma. That's more of like a blood cyst in the liver. They can get to be fairly large in size. They can occasionally, if they get large to 10 centimeters in size or larger, start causing symptoms, discomfort on the side. But those hemangiomas, unless they get to very large size, which is very unusual and rare, they never become cancer. They rarely ever grow anymore. And so those lesions don't need regular follow-up. On the other end, you have benign tumors like adenomas in the liver. Those have a risk of developing into hepatocellular carcinoma, into cancer. And so those patients need regular follow-up once a year to once every 6 months follow-up imaging. Now, if you are a AHP patient over the age of 50, you're going to get regular imaging every 6 months anyways. And so that interval of every 6 months imaging is pretty much, as frequent as we would need to follow up a benign lesion anyways. So I don't know the age of this particular patient. If this is somebody who's younger than the age of 50, then the need for follow-up and the interval for follow-up will depend on what type of benign lesion was found. All right. And then there was also the question of, right-sided discomfort and symptoms. That can be because of abnormal growths in the liver, even benign growths. I mentioned that, in the liver, what we tend to feel is an enlarging and stretching of the liver. And so if you have something, even a benign cyst that grows in the liver, if it's big enough, it'll stretch that liver capsule and sometimes you'll feel it. Okay. But I think in this case, it depends on what was seen on the imaging test. And then based on that, we could discuss further about the interval, if follow-up is needed and at what interval. And even a benign growth in the liver, if it is persistently causing symptoms, that would be a reason to talk to a surgeon about possible need for surgery to remove a benign growth in the liver.
Wow, thank you for that. Okay, when in a flare, I feel like my liver swells, causing severe sensitivity along my diaphragm to where even the seam of my clothing touching is unbearable. It ends up with a histamine dump causing anaph
Anaphylaxis?
anaphylaxis. Yes,
Yes.
thank you. With no known triggers. Is this common in porphyria, or is there anything else I can do to prevent it?
Yeah. So two comments there. Number one, there generally during acute attacks, patients don't get inflammation in the liver. Okay. There are, occasionally, I would say probably based on from what we have seen, maybe up to 1 in 7 acute attacks will have, if you are to look and do a blood test and look for liver enzymes, for example, that you can see that there is some mild to moderate liver inflammation during an acute attack. But by and large, acute attacks are really more nerve manifestations, neurologic manifestations, and don't correlate with inflammation or swelling in the liver. Okay, but it can happen, 15% of the time. But acute attacks, certainly, I think most people on this call are aware of the different kinds of neurological manifestations that it can lead to. And so the other symptoms of where, skin sensitivity to touch, more of a histamine reaction, those all can, and we've seen that associated with acute attacks. So that's not unusual, but and again, what I would recommend here is make sure that I would be checking urine for ALA and PBG around the time of these symptoms, and then trying to lower those high levels of ALA and PBG with panhematin during those episodes. And then if the ALA and PBG is persistently elevated or you're having recurrent attacks, then that's when I would consider something like givosiran to try to suppress the ALA and PBG and try to prevent attacks.
Okay. And speaking of Givlari and the testing for ALA and BBG,
Mhm.
someone from this group here asked if someone is on Givlari and still having true attacks, do you consider their ALA and PBG high, even though they're pretty low compared to before they were on Givlari?
Yeah, really good question. This also falls under the realm of what Kristen mentioned earlier of the need for more data. We've as a field we've had a pretty good understanding of what defines what is an acute attack in the past before Givlari was available. But now that we have a medication that is pretty effective at suppressing your ALA and PBG levels lower than your previous baseline, how do we interpret those test results, right? So, So this is how I still think about, even in the context of somebody on Givlari, how I still think about acute attacks. I think about an acute attack as somebody as occurring when the body's ALA and PBG levels are higher than the body's baseline. And the body's baseline meaning when, the few days ago, a week, 2 weeks, a month ago, when you were feeling better, when when you weren't feeling the current acute attack symptoms. Okay, and so really what we're talking about is a relative difference in your ALA and PBG levels while you're symptomatic from when you're not having symptoms. Okay, and so if you're on Givlari, it's very unlikely for you when you're having symptoms. And if those symptoms are associated with higher levels of ALA and PBG, it's unlikely for those levels to get up to as high as they were before you're on Givlari, because Givlari is a pretty powerful medication. It really suppresses the liver's ability to make and accumulate ALA and PBG that much. Okay, but I would still, my definition of an attack, acute attack for somebody who's on Givlari, is if your ALA and PBG levels while you're symptomatic on Givlari is higher than when you're not symptomatic while on Givlari. All right. And so it becomes a little harder for us now if we want to get into more detail. Well, how much higher do my ALA and PBG levels have to be when I'm on Givlari for and having symptoms for this to be an acute attack? That's where we run into the issue of we don't quite have enough data. Without Givlari, that was pretty well characterized. If, at the minimum, your ALA and PBG levels, PBG should be at least above 10 milligrams per gram creatinine and be higher than your baseline. And that would be my decision point to give panhematin. For my patients who are on Givlari, we don't have enough data. So I don't quite know, how high. There's also this unusual situation that I've seen sometimes in my patients where the ALA doesn't increase while on Givlari when you're having symptoms, but only the PBG does, right? That's a situation that we have not seen before we've had Givlari available. But I've tended to still treat patients who are on Givlari for an acute attack by giving panhematin if either the ALA or the PBG or both are higher than their baseline. As long as they're a little bit higher and you're having symptoms, I would treat you. Right. So, but that is an area where we need more research and more data, because that's now becoming, as more patients are on Givlari, this becomes this becomes a more common question.
Perfect. Thank you very much. Appreciate that. I find myself in that position sometimes, as we've talked about, Dr. Wang.
Yeah.
Okay, this question is for someone that has very good porphyria. They say, I had a jaundice of 30 point, had liver biopsy too, but its report does not provide us with much clearance. I want to know the reason of this much high levels of jaundice. Now it's okay. I have taken medicine. Don't know how much of it is just the porphyria alone or something else could be driving it. What are your thoughts?
Yeah. Um, uh, so I'm going to answer this a little bit more generally about how patients with AHP, including with VP, how the liver, what kinds of manifestations can we get in the liver? What kinds of injury can we get in the liver? As I mentioned before, you can get mild inflammation in the liver during acute attacks. It's pretty unusual for patients with AHP, even those who have recurrent acute attacks, to develop chronic liver injury to the point of developing scarring and advanced scarring and cirrhosis. So that's very unusual. Also, we do not see damage or injury or blockage of the bile duct system in the liver in patients with AHP. Where we see that, it tends to be only with patients with a different kind of porphyria, erythropoietic protoporphyria, EPP. Right? Those patients have a very different kind of disease pathology that can affect the bile ducts. So when I see jaundice and I see, a jaundice 30 points, I'm assuming that's bilirubin levels that are very high. Usually that's caused by, I think, about two things. Number one is bile duct obstruction. If you had a gallstone that went in to the common bile duct and blocked it, if you have injury of the bile ducts itself, if in our EPP patients, if you have, protoporphyrin crystals that block the bile ducts, that can cause jaundice, and the bilirubin levels to be very high. We don't see that in acute hepatic porphyrias, and we don't see that in variegate porphyria. The other condition is if somebody has cirrhosis already, the liver is very scarred down, and the liver, it's not the bile ducts that are injured, but that the liver can't process bilirubin. You can get jaundice that way. I'm assuming that, since this patient had a liver biopsy, that, if it was bile duct obstruction, that's very obvious on the biopsy, that would have been seen. If it's cirrhosis, that would have been obvious. That should have also been seen. So I'm assuming that that was not the case in here. Then that leads me to the other possible explanation for this would be a medication-induced liver injury can sometimes lead to this kind of biochemical picture in the liver. But the short answer is I don't think this is related to the variegate porphyria.
Perfect. Okay. These are more general questions, not necessarily just about the liver, but this person, which I think is a lot of question marks for many of us with AHP. Much of the info and literature out there seems to be on the extreme of severe attack symptoms, but there are some of us who who believe that we have attacks because of the severe pain that we are in, and we have other symptoms, but they don't compare to the very first big flare that we might have had. It can be very confusing to identify what is an attack because of the symptoms. Should we still consider getting him in during these flares?
Yeah, yeah, that's a really good question, and I think it's a really important question, and it's also a tough question to answer. So this is how I would think about it. I think from my perspective, and this is thinking about this, from the perspective of making a treatment decision, right? We have two medications, and in this case, well, let's just talk about one. We have panhematin as an available medication that can be used to treat and stop an active acute attack, relieve symptoms. All right. But I think about it mostly panhematin as a way to rapidly lower levels of ALA and PBG. Okay. In fact, I think of givosiran in the same way. It's a medication that we give on a monthly basis, again, to lower levels of ALA and PBG. So for me, I separate out when a patient is having symptoms of acute attack, I separate out symptoms and high levels of ALA and PBG. Okay, so there's two situations that can happen because every attack, every acute porphyria attack that starts off being associated with high levels of ALA and PBG is an episode of nerve damage. And our nerve cells in the body are such that when they get damaged, they take a long time to recover and heal. And nerves that have been repeatedly damaged, they can have residual damage even if the initial underlying cause of the damage is already gone, right? We talked a little bit, earlier when we talked about liver transplants, how patients with chronic neuropathy as a result of recurrent attacks, that doesn't resolve even with a liver transplant, right? Because you can have symptoms because of permanently damaged nerves, okay? So when it comes to acute attacks and whether or not this should be an episode of symptoms should be treated with panhematin, I have a relatively more simplified view of it. We should give panhematin if the levels of ALA and or PBG are higher than your baseline when you're not having these symptoms. And I make that decision because the way that panhematin works is by lowering levels of ALA and PBG. It provides heme to the liver to tell your liver to not make any more heme, and that stops your liver from accumulating more ALA and PBG, okay? We don't know the effectiveness of heme on nerves directly. right? So there are, there's proposals out there and studies using cell culture about the effects of heme on damaged nerves, but we don't actually know how well that actually, how important that is in the actual symptomatic improvement in patients who have an acute attack while they're getting treated with hemin. We know that hemin lowers ALA and PBG, and so my decision about when to give somebody, when to recommend hemin is, are your ALA and PBG levels high? And I separate that from, so if you have symptoms, and the symptoms may feel exactly the same as when you're having high levels of ALA and PBG, but if you're having symptoms and the ALA and PBG is not elevated, I don't recommend giving hemin because I don't think it's going to be effective.
On that vein, the results of getting an ALA and PBG test are not going to come in right away. They're going to come in
Correct.
7 days later. So, in your opinion, should we still have panhematin administered, even though we're not going to have the answer of the PBG and ALA until much later?
Right, right. And you bring up yet another really good question. And this is still I think, a highly unmet need in this country right now with laboratory testing for acute porphyria patients, that we don't have rapid PBG tests or ALA tests available. And so, even though I can say, hey, I want to make my decision to whether to give this medication or not based on the results, the reality is that the results are not going to be available until, as you said, minimum 3 days, probably 5 to 7 days after we test it. All right. So this is my current practice, which is the first time that you have an attack, or maybe the first time in a while that you've had an attack. And let's say you're on Givlari. I would treat you empirically. Okay. But before we give any panhematin, I want to get a urine ALA and PBG. All right. That the test, it's not to that test result isn't going to affect whether or not I'm going to give you hemin now. But that's for after the fact. We can come back and review, do we make the right decision? Okay. And in fact, the second episode you have, I'm still with you empirically. That's still be my recommendation because, I don't quite know what the pattern is yet. Right. But let's say if you have 3 attacks over the course of 3 to 6 months or 4 attacks, right? Then by the third or fourth attack, if all of the previous ones, every time you have these episodes of symptoms, the ALA and PBG comes back and they are no different than your baseline. Then on the first episode or the fourth episode, then we can try something different, right? Then it's, all right, let's give symptomatic control. We'll still give IV Dilaudid, Zofran, IV hydration. But let's hold off on the hemin for a couple of days and let's see if the other symptomatic treatment can get you through and get you enough relief, right? That's how I have been managing these kinds of situations. Now, it's much easier to do that if you have access, especially to an outpatient, infusion center where you can get hemin on a regular basis. That also helps avoid hospitalizations. So, this way of doing things does it does require some setting up and some access to resources, which may not be available to all patients depending on where they live.
Right, for sure. You mentioned that in this country, we don't necessarily have those rapid tests available, but do other countries have a system that allows a much quicker turnaround?
Most ones don't either because and some of this in other countries depends on location. So for example, in Europe, I think most countries in Europe have one central, one particular lab that's usually based in a academic medical center with a porphyria clinic that processes and runs all of the ALA and PBG testing. And so if you happen to be a patient who presents to that particular hospital, you you probably can get same day testing results to come back, but if you're anywhere else, that's very difficult. In the US, all of our large reference laboratories pool their samples together and run them like 2 days a week. The only place where you could potentially get it on the same day is if you're a patient at UT Galveston, where Dr. Carl Anderson has his own lab that can run a clinical laboratory that can run urine ALA and PBG. And so there you could potentially get a same day testing back. But again, even if I were to send the sample to Dr. Anderson's lab, there's still going to be a lag and delay of that shipping time. Mount Sinai used to have their own biochemical lab, but I don't think that exists anymore. And I think they're also using reference laboratories. So basically, in this country, all patients, all of our tests are being sent out to, ARUP, Quest, LabCorp, or Mayo Clinic. And so there's always a delay. And even in Europe, in most cases, there are delays.
Okay. So is there such a thing then as an instant PBG and ALA or not
There,
really?
There is. It's not as accurate. There's a PBG test that's available. It's a
Okay.
semi-quantitative test, so not as accurate as especially a lot of the central laboratories are doing mass spectrometry-based testing. But in the setting of an acute porphyria attack, a semi-quantitative method is good enough. There are a couple of technical issues here. For a number of years, there just was no longer a manufacturer to make these semi-quantitative kits. As a few years ago, there is now a manufacturer in the U.S. for these kits. Now the problem is that most hospitals, their laboratory has very strict rules about who can run tests and who cannot. The purpose of these same day tests is that they work best if there are a bedside test. Basically, if you present to the emergency room, if that ED physician can take a sample of your urine and then just apply it into this test, we'll get an answer in like half an hour. Okay. The problem is that right now, these semi quantitative tests, the way that the regulatory system in the US works for laboratory testing is that, for example, I can't do diagnostic tests because even though I'm a physician, I am not certified to run, a liver enzyme test, right? So that is, that certification is only given to people in the laboratory and laboratory technicians. So even if you have this rapid test available, only certain people can run it. And that has led to the rollout and actual use of this in especially in the emergency room setting, to be very limited. I try to get that, get the UCSF hospital system to allow us to use that test, and we couldn't do it.
Wow. So really, we don't have a way for that to be valid for determining an attack because it sounds
Correct.
okay.
Correct. Basically, if I were to run that test, I can't use that test, to justify clinical decision making. Now, I doubt, that a patient is going to sue me for, giving them panhematin based on this test because I wasn't certified to do it. But most physicians are not willing to take on that risk. So even though a test like this is available, it's not used.
I see. We have 4 minutes left, so we'll see how many additional questions we can get through. But here's a question that I think is very valid for many of us that have AHP. How common are mild muscle cramping in the lower extremity during attacks? A mild cramp in the torso and abdomen progression of an attack. Like I think of this as someone described it in our AHP focus group that they feel like someone is literally hugging their torso and they're difficult to breathe, like someone is wrapping them around and very difficult to breathe along with these muscle spasms. How common are these during flares?
Very common. Flares of acute porphyria, nerves everywhere in the body can be affected. So these are common. It's going to be, across different patients. You will have oftentimes slightly different variations. We looked at this in about 400 US AHP patients in our longitudinal study. And if you look at this, these kinds of, let's say, peripheral muscle aches and pains, peripheral neuropathy type of symptoms, that occurs in about 50 to 60% of patients. Still, the most common shared symptom is severe abdominal pain. That was about 95% of patients had that across all of their attacks. But this lower extremity muscle ache, that is also still a very common and shared symptom across many different patients with AHPs. I know that we're running up on time, but I did want to, because I see this question come up a few times in the chat here about testing. So a random urine test, a spot testing for PBG and ALA is the recommended test. It is a valid test for determining an attack. If you're on Givlaari, what I do with all of my patients is right before your monthly or whatever your regular interval is for Givlaari, right before that dose, I always ask all of my patients to check a set of urine for ALA and PBG. What I want to know is right before your dose. Theoretically, that's when the Givlaari has its least effectiveness. What is your level of ALA and PBG? And that's what I use as a baseline to help determine things like duration and dose of Givlaari, and then also to use to compare if you are having symptoms, to compare with the ALA and PBG levels during symptoms. Right, so I test for urine ALA and PBG a lot. I don't think you can overtest for ALA and PBG. I think by and large we don't test enough.
I was not being tested on a monthly basis at all until I came to you, and now we have a trend. We can actually see what
Yes.
happens in my body, which has been such an eye opener. Thank you for answering all of our questions. We still have a lot of questions left, so I know Dr. Wang, you're really great at responding to some of these questions. You
Mhm.
record yourself, you send them to us, so we will do the same for some of those outstanding questions that we still have. So don't fear if we didn't get to your question, we will get to your question, even if it's not in a formal setting like this. We'll get to your questions. Dr. Wang, thank you so much for your time. Really appreciate it. I still have a few things to go over with you, but Dr. Wang, you are free to go if you would like. Thank you so much for spending an hour of your lovely time that you could be with your family. You've decided to spend it with us. Really appreciate that.
Of course, of course. Happy to be here. Glad to do this anytime. Thanks, everyone. Have a good
Thank
weekend.
you. Bye, Dr. Wing. All right, guys. So the rest of us, just for a few minutes, I just want to go over some exciting things coming up. One of them is Porphyria Palooza. It is one of the best events that the UPA puts together for our patients, our families. It's an opportunity to just be you, be with a group of people that you don't even have to say a darn word, and people just get you because we all come from the same place of pain, same place of shared journeys. Might look a little different, but at the end of the day, we all understand porphyria better than anyone else, better than a textbook because we've lived it. And this is an opportunity to have fun. We're going to have studio games, like we're going to have opportunities to connect with people and be able to have one-on-one conversations. We will also have an opportunity to consult with doctors. So Dr. Wang will be there, Dr. Amy Dickey Urn will be there as well. So a whole bunch of other, excuse me, opportunities to really enjoy, make the best out of this time. So please don't miss it. It's October 9th through the 11th. So we have travel stipends. If you have not signed up yet, I urge you to do it. I urge you to. Sorry, my voice is clearly cutting in and out. I've been fighting a whole bunch of symptoms for the last 24 hours, but let's get through this. The other thing that I wanted to acknowledge is that we have the opportunity for you to be able to raise your own funds. If beyond the $500 that the UPA is willing to give you, you need to raise additional money to get your family there. You're more than welcome to be part of our Zephy fundraiser. You can create the amount that you need, and that is posted on our chat here. This Zephy account will allow you to create your own fundraiser campaign. You can send it to your friends, to your family, and through that, be able to reach the amount that you need. The other thing is that we have a mental health webinar coming up. It is called Give an Hour. The individuals will come in and talk to us, but it includes how to live with porphyria and how it can affect your emotional well-being, how past experiences shape our response under stress. the impact of uncertainty of self-advocacy and medical trauma, recognizing and responding your emotional needs. This is a very important thing for all of us that are patients and or for you caregiver to be able to help your loved one out. The crisis support resources and where to find help. So I urge you to sign up for this webinar coming up. It's going to be Monday, the 31st of August at 7 p.m. Eastern. And additionally, I encourage you to sign up for our e-news by clicking the Join Us button on our main page. There's an opportunity for you to click Join Us, and that gives you automatically a chance to receive all of our monthly newsletters so you don't miss absolutely anything. We have Connect Ups. These are small groups and the ability for you to not feel alone by being part of a small group that allows you to connect deeper with patients within our community. We also have an ambassador program that allows us to connect one-on-one with a patient. If you're going through a moment of need that you need to talk to someone or you know someone that could use help connecting to maybe a person that is going through a similar situation with them, or they just simply have recently been diagnosed and they want to connect with someone who has the same diagnoses, we allow that to happen through our peer one-on-one support. And then lastly, we have our patient navigator, which provides support for those individuals that are trying to navigate their diagnosis journey with porphyria. Erin is fantastic. We also lastly have a tremendous private group on Porphyria Together. If you're not on Facebook yet and you don't feel the need for it, trust me, you want to create a Facebook account just to be a part of our ongoing chats on Porphyria Together. I've learned so much in the last year just from learning from other patients, different walks of life from other individuals. I've had the opportunity to just witness how many connections have happened of the result of this private group. No one can see your postings, by the way. None of your friends and family can see your postings on Porphyria Together. They're completely private. They are just up to you unless you've invited someone into that group that you know it is completely safe for you to be open and vulnerable in that particular group. And lastly, I did say lastly for Porphyria Together, but guess what? I wasn't done yet. We have our share your story feature as well. We would love to share your story. We have had patients that have been diagnosed just by hearing somebody else's story. They compare notes and they're like, oh, wow, I've gone through the same thing. So if you have not shared your story with us yet, I highly urge you to do it. It's on our website. You can't miss it because if you go into the drop down for on our website, there is an option to that says about us, and then it gives you an option for our stories underneath. So I would love for you to be able to share with us your story. You don't have to do a lot of the work yourself. All you have to do is create a portion of your story where you get to write it, or you let me know that you need my help to write it out. And then Kadri will collect pictures and videos and she will make a beautiful reel out of your content. So we make it super easy. We would love your feedback for today. If you're kind enough to give us some feedback, if you don't like the moderator, be honest and say, please get rid of that girl. She's just super annoying. Whatever you want to write on the feedback, that Dr. Wang is amazing and that you really enjoyed today's lesson. Whatever the case might be, I definitely urge you to give us your feedback because it allows us to provide better content for us as patients to continue to learn. So with that, thank you so much. Enjoy the remainder of your beautiful weekend, and I will see you in the next one. Thanks so much. Bye.